So the beta-1 receptors act primarily upon the heart, increase the rate, automaticity, contractility, etc. Beta-2 receptors do what? Okay, they act in the lungs. Primarily, what do they cause? Bronchodilation. Now, when I give a medication systemically, I give it into an IV, is it safe to say that that medication is going to act pretty much throughout the whole body? So if I give a medication that has beta effects, and maybe it affects both beta-1 and beta-2 receptors, if I give it systemically, am I going to have cardiovascular effects occurring? The heart. Yes, I'm going to have cardiac effects. If, however, I give that medication locally into the lungs, am I going to have as many cardiovascular effects? No, I'm not, because I'm giving that medication locally. It's acting right there at the lungs, in the bronchi, in the bronchioles, and I don't have as much crossover effects. However, can I still have crossover effects occurring if I give these medications? Good. Okay. Now, last week I talked about albuterol, and I said albuterol is a beta what agonist? A beta-2 agonist. So we would we all assume that it causes bronchodilation. Everyone agree? Okay. Good. Do you think that albuterol is a pure beta-2? No. That's all it does? No. Is there still a little bit of beta-1 crossover? Yes. Yes. So can we get tachycardia? Yes. Can we get elevated blood pressure? Can we get nervousness, anxiety, and tremors from the beta-1 crossover from albuterol? What do you guys think? Yes, absolutely, we can. Now, do you think we get as many beta-1 effects with albuterol as, say, a catecholamine like epinephrine? No, because epinephrine acts pretty strongly on both beta-1 and beta-2. Albuterol is a little more specific to beta-2. Does that kind of make a little sense there? So our choice of medications, and this will lead into next lecture when we talk about the bronchodilators, our choice of medications may depend on what's going on with the patient. If our patient has heart problems, some kind of cardiac problem, are we want to look at giving them a medication that has a lot of beta-1 effects? Maybe not. Maybe not. Okay. All right. So disadvantages of the aerosol route. Well, several factors influence the amount of drug that actually gets to the lungs. And we're going to talk about these factors. This will be very important. Often patients will self-administer, and are patients often compliant with their therapy? How many people have asthma here? Nobody has asthma here. Wow. It's incredible. Well, I was recently diagnosed with asthma as an adult. And how compliant do you think I am with my medications? Not at all. Very poorly compliant. And I'm an educated person. I'm a respiratory therapist. And if you were to ask me, hey, Chris, do you have your albuterol meter dose inhaler on you in case you need to rescue yourself? In my spacer. What do you think I'm going to say? No, it's 70 miles away at home. So patients are often not as compliant as they could be. And there's a certain way that we need to use these medications, administer them, to have optimal delivery and absorption and so on of that medication. Okay, so this is just a table of advantages, disadvantages. I think this comes straight out of your guys' book here. We talk about smaller doses, fairly quick response, much fewer side effects when we give medications via the aerosol, inhaled aerosol route. It's often painless and very convenient. We don't have to place IVs and do a whole bunch of craziness on our patients. However, it is very difficult to deliver consistent and precise doses. It requires a lot of compliance and education, and there's equipment. And obviously there's a certain amount of maintenance that goes into equipment. And if I'm at home and I have a small volume nebulizer, what do I need? Well, I need a machine that can nebulize, or I need a gas source, or if I have a metered dose inhaler, well, I need to have the inhaler, it needs to be intact, and it needs to be in date, and all these other things kind of come into play. And then, what quality of medications are we getting? Because how many people here are on medications and know how expensive they can be? Yeah, they can be pretty expensive. Even if you have insurance, you still get hit with the old copay. So how many people like me drive to Mexico and get their medications?
No.
Oh, no? Okay. They're expensive. They're really expensive. So you might have people using alternative routes to obtain medications, and the quality may or may not be good. You know, it's hard to say, even here in the United States, what just occurred over the weekend. FDA put it out. Millions upon millions of these were recalled.
We were all studying, we weren't watching TV.
Oh, no? Oh.
Yeah.
Oral contraceptives. Millions upon millions of them have been recalled. Many unintended pregnancies have occurred, and apparently there was a major manufacturer error. Oral contraceptives.
Oh my gosh.
Yeah, big deal. So even in our own country, there's not necessarily a guarantee that a certain lot of medication, there's never a 100% guarantee, let alone going to other countries where they may not have the regulatory processes in place that we do. Okay, this is a blue light special here, these concepts. These are factors that influence drug delivery within the lungs. Okay, so the first one is stability. And that's a tendency of an aerosol to remain in suspension. Because the stability is important that the patient holds his or her breath so the particles rain out into the lungs. Okay. So you guys can all imagine that when I aerosolize a medication, it's a little particle floating around. Everybody's okay with that? It's a little particle floating around. Even though it's a tiny little particle, does gravity act upon it? Yes. And will it have a tendency to, obviously, be pulled to the earth because of gravity? Will it want to go down eventually? We need to give it time, though, right? So if I'm breathing 50 times a minute, like this, breathing in very quickly, breathing out very quickly, do you think I'm going to have a whole lot of time for that little particle to kind of settle down? Okay? Because when we give an aerosolized medication, do those particles just instantaneously, when they get into the lungs, instantaneously pass through the membranes that they need to and attach to beta receptors? What do you guys think? No, because if you remember from pharmacokinetics, what do I need? I need to have absorption occur. And for absorption to occur, I need to allow these particles to rain out and fall onto the membranes or smash into the membranes that they need to smash into to go through those membranes. And we'll talk about the optimal breathing pattern. Penetration refers to how far into the lungs the aerosol particle travels. This is related to many factors. Size of the aerosol particle is a big one, and we'll talk about that. The patient's breathing pattern and their disease state. Maybe they have a large obstruction and we can't get that medication into where it needs to go. Deposition, again, these are more blue light specials here, refers to the aerosol products particles falling out of suspension. Obviously, this is basically the same factors that affect deposition are going to affect the stability. It's basically when the stability diminishes or finishes, if you will, the particle doesn't loses its stability and rains out. When that rain out occurs, we get deposition. Those little particles are deposited where they need to be, or sometimes where we don't want them to go. And then inertial impaction. And this will kind of lead you guys into physics next semester. I'm not sure who's going to be teaching your physics, but if I am, this is going to be something that we will talk about again. What is inertia? What is inertia? It's one of the greatest thoughts of modern Western civilization. And it came from a guy by the name of Isaac Newton in the 1700s, and he developed 3 laws and called it the laws of motion, Newton's laws of motion. We now know through quantum mechanics that they aren't quite right, but they still work for most of what we'll do. The first law of motion is inertia. And basically what that is if I have a particle, or a bowling ball, or anything, I have something that's not moving, is it going to want to move? If I just have something sitting on a table, is it just going to instantaneously want to jump up and move? No. What do I have to do to make it move? I have to act upon it with a force. I have to apply force to it. Now, if I have an object that's moving, does it want to stop? No, it doesn't. No, it doesn't. It wants to keep going. Now, that's really not intuitive if you think about it, right? Because if I push a chair like this, it stops rather quickly. So the intuition is, well, Chris, you're totally wrong. The chair just stopped. But this is where having a really good imagination comes into play and realizing that, is this chair being acted upon by forces while it's moving? Yes, forces are making it slow down. However, let's say imagine that we go into outer space now. There are no objects around, no gravitational influences, and I give that chair a little push. What do you think is going to happen? It's going to keep going and going and going because there will be nothing to stop it. Does that make sense? And Isaac Newton realized that back in the 1700s. That's a huge step for somebody to take, 300, 200 some years ago. I mean, that is a huge step for someone to take. And that's what inertia is. It's a tendency for an object to stay at rest unless we make it move, or to stay in motion unless something happens. And hence the term inertial impaction. And that is nothing more than the impaction of aerosol particles upon airway walls. And obviously they give up their energy when they impact because they have a certain amount of what we call kinetic or energy of motion. Where this becomes important is the speed of the delivery device and the rate of breathing. And we'll talk a little bit about why that's important. Okay, size. Size is one of the most important factors in determining whether or not I can get an aerosol where it needs to go. Are you guys familiar with the term micron? And this will be a blue light special. Again, I'm not going to have you doing math problems using microns, okay? But I want you to know what a micron is. It's equal to 1 millionth of a meter. So 1 millionth of a meter. That's tiny. Very, very tiny. And we measure these particles through the microns, a very tiny size, microscopic. Okay, this here is a blue light special, particle size. Particle size is very important. So, if I have a particle that's between 10 and 15 microns, that particle is going to get stuck in the upper airway, primarily the mouth and nose. Well, that's great if we're giving nasal spray. Let's say I'm giving myself a nasal steroid. I have allergic rhinitis. I have allergies. Do I want that steroid to deposit, to have deposition in the nose and mouth? What do you guys think? Yeah, that's where I want it to. So do I want really small particles of that nasal spray? No, I don't want that to go down into my alveoli or my bronchioles or my bronchi. I want it to deposit in the mouth and nose. Okay, so 5 to 10 microns, the particle penetrates to the large bronchi. These are your right, left main stem, the large bifurcations. 1 to 5 microns, these particles penetrate to lower airways where most bronchodilator drugs are needed. So this is of utter most importance, the big blue light special here, that if I'm giving a bronchodilator, it needs to be between 1 and 5 microns. If it's smaller, if it's less than 0.5 microns, these penetrate all the way to the alveoli, and they may not even be deposited. They're so small, they have such little amounts of what we call inertia, their inertia is very small, that we can breathe them in and exhale them, and they will never be deposited. Never be deposited. So when we're giving somebody a nebulized medication, we need to be very careful about the size. And that's going to relate to how fast. And you guys haven't experienced this yet, but you may experience this when you go into the hospital, and the therapist that you're with says, oh, crank that nebulizer up to 12 liters a minute. It'll get it in faster. Yes, it will. But what could it do to the size of the particles? Make them too small, possibly? What do you guys think? Possibly make them too big? Hard to say. There's a prescribed flow rate. And you guys will learn this, but generally it's 6 to 8 liters per minute through a small volume nebulizer. That's generally, some of them are different, But you want to go with what the recommendations are, manufacturer recommendations are on that, because the size of the particle is going to really depend on the flow of gas through there. And we want to have inertial impaction and deposition to occur in the right area of the airway. And this is just kind of a picture here. So here you go. You have your 10 to 15 in the nose and mouth. 5 to 10 microns in the first 6 generations. You guys are familiar with the term generation? And that just stands for a bifurcation. When I have a bifurcation, I have a generation. And then 1 to 5 microns in the last 5 to 6 generations, less than 0.5 microns. And you're looking at the alveoli, but you may not get rain out, and you may not get good delivery of that medication. Okay. Breathing pattern. This is really interesting. Studies estimate that only around 10 to 50% of a drug will actually get to the lungs under optimal conditions. So under the best of conditions, we're only going to get about 10 to 50%. That's a huge variability. Would you guys agree? Yeah. If you're doing research and somebody says, "Oh, we have confidence between 10 and 50%," that's a delta of 40%. That's a big variance there. If anybody's taken statistics, boy, the standard deviation on that is going to be huge. So what does that tell us? Well, that tells us that there are lots of different things that go into delivering a medication properly. Lots of different things. And we've talked about some of them already. If poor technique is used, and guess what? Guess what you're going to see often? Poor technique being used. Only about 1 to 2% of the medication may actually be deposited in the lungs. This is a blue light special here. The optimal breathing pattern. Now again, I say optimal. This may not be real life or real world, but the optimal breathing pattern for effective aerosol delivery that allows for maximum penetration and deposition is a slow, deep breath through the mouth with an inspiratory hold. So I want to take a slow, deep breath. Hold it. Why am I holding it? There we go. I'm allowing for rain out. I'm allowing for inertial impaction to occur at the right size of airway. And then I'm going to exhale slowly. So the big thing that we need to know is a slow, deep breath with an inspiratory hold. Do you think that's going to be hard for people that are in respiratory distress? Somebody having problems with their asthma? Yes, it'll be very hard. And you may not get this optimal breathing pattern for them. But we strive to do that. We strive that we should educate our patients when you're in clinicals and you're watching somebody take their medication, educate them how to properly take it. Okay, slow breathing minimizes inertial impaction. So again, if I breathe very quickly, I breathe in rapidly. Where are those particles more likely to impact? If I breathe in very rapidly. Back of your throat, absolutely. I'm going to have inertial impaction occurring at the back of my throat. Absolutely. Another reason that we want to take a deep breath and hold it, so deep breath and hold it, another reason is something called Brownian motion. Have you guys ever heard of Brownian motion? Anyone ever heard of that? No? Okay. In 1905, a groundbreaking paper was released by one of the greatest scientists of the modern time. Who do you guys think that person was? Einstein. There you go, Albert Einstein. And most of us would say, "Oh yeah, that's all right. He wrote a paper on special relativity. Spaceships and time warping and all that cool stuff." He wrote 3 papers in 1905. One paper was on special relativity. Another paper was on something called the photoelectric effect. And anybody who's taken lots of chemistry and physics should know that very well because that ushered in quantum mechanics. And then the third paper was on something called Brownian motion. And what that is that is the random motion that particles have. And you guys have all taken anatomy and physiology, correct? And have you looked at things under a microscope? And was that stuff still that you looked at? Completely still? No, it moved around. Even though you weren't really doing anything to it. It moved around. It had what we call random movement. That's called Brownian motion. Stuff randomly moves, and that always happens. Just random motion that occurs at the microscopic level. So, do you think those particles that we breathe in are going to be randomly moving around? So, if we take a slow, deep breath and we hold it, will that random movement, that Brownian motion, enhance the delivery of those particles to certain areas of the lungs if we allow it enough time? What do you guys think? Yeah, absolutely. So we have lots of different things going for us. We have inertial action, we have the size of the particle, we have how we're breathing, we have Brownian motion. We have all these different concepts that go into properly delivering medication. Breath hold allows, obviously, for these very small particles to deposit terrain out, and so on. Okay, so this is just talking about distribution. Don't worry about this too much here, guys. Again, this is in your book, but the major point for today is we want slow, deep breaths with an inspiratory hold. It's our optimal breathing pattern. Okay, types of aerosolized medications. Nasal decongestants. You guys, anyone ever taken nasal decongestants? Like Aspirin, things like that? Okay. There's some interesting stories I have about that. Neosynephrine is a big example of a nose spray. Neosynephrine is a medication that has very potent alpha-1 effects. Alpha-1. So what is that going to do? That's going to cause what? Vasoconstriction. Is that going to dry the nose up? Yeah. Yeah, it is. Can it help with bleeding as well? Nose bleed? Yeah, because it is going to constrict vessels of the nose. So often you will see neosynephrine used for people that have what's called epistaxis or a nosebleed. And again, it has very strong alpha-1 effects. Bronchodilators, we give a whole lot of those. Enlarge the diameter of the airway. They relax smooth muscle. In the next lecture, we're actually going to dive into how this occurs and some really interesting processes that occur. But we'll save that for next week. Proventil and Atrovent. Everybody knows what's the generic name for Proventil? Albuterol. That wasn't on the test, was it? It was. All right. Atrovent. What's the generic name for Atrovent? Starts with an I. Ipratropium. Okay. So Proventil is albuterol. It works on what receptors? Beta 2. Okay. Atrovent. Is Atrovent a sympathomimetic? Or does it work a little differently? It works a little differently. It doesn't work on the sympathetic nervous system, but it works on the parasympathetic nervous system. And what it does is it blocks the parasympathetic nervous system. It is a parasympatholytic, if you guys remember from last lecture. So that's how it works, a little differently. Okay, antihistamines or mast cell stabilizers, and we'll talk about those a little bit. But basically, are you guys familiar with mast cells from anatomy and physiology? And what happens when they degranulate and the pro-inflammatory substances that they release when they degranulate, and that can cause inflammation, allergic or atopic responses, and so on. Antihistamines block the histamines that are secreted by these cells, and mast cell stabilizers prevent the cells from degranulating in the first place. You don't see these given a whole lot anymore, the mast cell stabilizers, but you still see them talk about them on tests occasionally. Antihistamines are obviously very common. So they desensitize the allergic response, decreases the incidence of asthma. Examples of these types of drugs are cromolyn sodium and nedochromyl sodium. Cromolyn and nedochromyl are both mast cell stabilizers. They are not antihistamines. Medications like Benadryl or diphenhydramine, loratadine, citrazine are all antihistamines. And we'll talk about those in more detail later on. Corticosteroids. So where do corticosteroids come from? Okay, they're related to cortisol, or cortisone. And where are they produced, manufactured? A hormone? Adrenal? Someone said adrenal? Okay, what part of the adrenal gland? The cortex or the medulla? Cortex. If you ever have issues with terminology, generally it's hidden in the name of the word. So if you know that a steroid comes from the adrenal gland, if it has a cortico in front of it, you can assume, oh, it's adrenal cortex we're talking about. Just like adrenal is telling us about the location of the adrenal gland in the first place, right? Because it's ad, which is on top of renal, kidney. And that's literally what adrenal means. Okay, so they're used in moderate, severe asthma attacks. They reduce inflammatory response. They work very differently than antihistamines or bronchodilators. And we'll talk about how they kind of work a little later on. But they modulate, they change the way our immune system works. They, in essence, suppress the immune system. Lots of different Asmacort, Flovent, Vansoril are different examples of medications that have steroids in them. A lot of these medications are actually combinations. They have a bronchodilator and a steroid. A big blue light special that I will throw in here is if I give somebody an inhaled steroid, what should they do after they take that steroid?
Drink water or spit it out?
There you go, rinse their mouth out. Because what can steroids inhaled cause if I don't rinse them away in the mouth and the oral pharynx? They can cause what? They can cause infections, right? They suppress the immune system. They can cause infections. And a big problem that you can run into with people that take inhaled steroids is something called thrush. You guys know what thrush is? It's candidiasis, which is yeast. And that can be very hard to take care of in certain patients, like patients that are compromised or immunosuppressed. So if you are administering somebody a medication that has a steroid in it, have them rinse their mouth out after they have taken that steroid to prevent infections like thrush. Okay, mucolytic medications. These are medications that break down secretions, make it easier to expectorate or cough them. Often they are given by nebulization. Sometimes we'll actually directly instill them into the lungs in their liquid form. Generally, we'll do this if we were looking at doing something called a bronchoscopy on somebody, where I actually have a scope. And we actually have a bronchoscope here. I'm not sure when you guys get to see that and use it, but you see the little red crash cart back here? There's a white box on the left-hand side of it. The bronchoscope is actually in that box. You guys can be free to take a look at it. And, it's really, you'll do a rotation, I believe, through bronchoscopy. And you actually get to help perform the bronchoscopy. It's really, really neat. But sometimes people that have really bad secretions in their lungs, you actually have to go in with the bronchoscope and actually pull those what we call mucus plugs out. And sometimes what they'll do is they'll administer that mucolytic in its liquid form directly in the lung without nebulizing it. Often, though, we will nebulize it and get it nebulized. A big blue light special, it's not something I'm going to cover in depth today, but it is something that I'm going to want you guys to know about with mucolytics. If somebody has a mucolytic order, and the big ones that we run into are going to be mucomist. I'm going to talk about some specialized ones for cystic fibrosis, and there are certain ways that we have to administer them, but we're not going to talk about it today. We actually have a lecture on mucolytics. If I have a mucolytic ordered on a patient, I have to give that with a bronchodilator, or give the bronchodilator before the mucolytic. The reason being is these mucolytics, like mucomist, can cause bronchospasm. They can irritate the lungs. They can cause bronchospasm. So the blue light special here, the take-home point is never, ever give a mucolytic without giving a bronchodilator with it. Is everybody okay there? Because you can potentially cause some really bad bronchospasms and really hurt your patient or possibly even kill them. So you've got to give a bronchodilator if we're giving mucolytic. Antimicrobials, there are lots of different bacterial infections that we worry about, and we can aerosolize certain antibiotics. Gentamicin, amphotericin B, ribavirin, we'll talk about these in a little detail. I will give you guys a little blue light special, not today, but it's coming. Some of these medications require special nebulizers. And I'm not sure if you guys have talked about that yet, but there's something called a SPAG.
That's on the drug cards.
Is it on the drug cards? Okay, good. I'm glad you picked that up. There are certain medications that require special nebulizers. There's a SPAG nebulizer. There are other types of nebulizers, and you'll come across questions that'll ask, "Hey, this patient has ordered this medication. What nebulizer do they need?" So it is important, at least for today, just to know, okay, some of these medications require a special nebulizer. The bronchodilators, not so much, but some of these others, yes. Okay, so let's talk about the types of delivery techniques. We have something called the metered dose inhaler. This is something that you should get a hold of in lab. Has anyone ever seen an MDI? No? I've got a picture of it. It's just a little canister, full cylinder, that kind of goes in a little collar, and you squeeze it, and it shoots out a mist. So it has a medication mixed in a propellant. It's a small, portable device that can effectively deliver medication to the respiratory system. Has a propellant inside of a canister, it's a pressurized canister filled with medication. It's really handy, real easy to use. Usually it's self-administered. The problem that we ran into, anyone here in healthcare back in the 80s? No? Okay. Oh, boy. So what they used to have chlorofluorocarbons, or CFCs, and what do we know about CFCs now? Yeah, the ozone layer. Yeah, the ozone hole in the ozone layer. You guys remember that from the 80s? That was huge in the 80s, wasn't it? It was like all over the hole, and we're all... No? You guys are...
Never born.
You guys that are at least 30 remember that? That was a big deal in the 80s. Yeah, the hole in the ozone layer. It was it was over Antarctica, and yeah, big deal. It's actually still a big deal. But the older propellant was CFC based. The newer propellants use HFAs, or alkanes rather. You don't have to remember. HFAs, which do not damage the ozone layer. And here's just a kind of a picture of a metered dose inhaler. And again, these things are small and handheld. But I have my container. I have my drug and my propellant mixed. Obviously, there's pressure here. I have my little actuator nozzle. The canister seats in here, and a little valve. And what you do is you push down on this. This goes in, opens up, and then the propellant with the medication is squirted out this way. It goes through a really narrow nozzle here. It's called the actuator nozzle, real narrow opening, and it's nebulized as it goes through that real narrow opening, and it comes out in fine particle form. Often we will use what's a reservoir device. Anyone know the name of these devices, the common name that you'll see? Spacer, yes. A blue light special there. Spacer. And what will happen is they will add the spacer to the end of this. And what that does is, in somebody like a little kid or somebody who has difficulty breathing actively, I can spray that and it will go into the spacer and it will stay in suspension for a while because there's Brownian motion and all that, and it'll float around in that spacer and it'll give that patient time to inhale it. If the patient is having difficulty, and we'll talk about actually how we administer these, because it can be a little difficult to administer. And a lot of times what will happen is you'll spray it and it'll shoot right in the back of the throat and you don't get a whole lot of medication. But I had a spacer on there, and then I have kind of this wide open area with all this medication floating around, and it allows me to inhale. Okay, reservoir, yeah, we talked about that. Two types, spacers and holding chambers. We'll pretty much use those interchangeably in this class. Spacers are simply extensions placed between the MDI and the patient. A really old school thing that you may see used, and you'll see this at MMC with certain therapists, is they will actually use a paper towel, the roll, the cardboard tube, or that paper towels, or toilet paper is rolled up around. And they'll actually use that as an extension and use that as a spacer. And that works reasonably well. And then holding chambers are spacers that have one-way valves. Hold the aerosol in there until the patient inhales, the valve opens up, and it goes in. Okay. The advantage of a spacer, it's great because I have this holding chamber here, allows the particles to slow down a little bit, and it gives patient time to coordinate inhalation. And I'll just talk about it a little early, but when we talk about giving a meter dose inhaler, optimally what we want to do, or what we need to do, is you'll actually hold it a couple centimeters away from your mouth. So you probably see when people, on movies or whatever, when people take that, they cram that thing right in their mouth, right? And they seal their lips around it, and they squirt it, and it squirts all over their mouth and doesn't do much of anything. So ultimately, you need to hold it away from your mouth, open your mouth up, begin inhaling, and then shoot it, and as you're inhaling, it'll go in. How hard do you think that is to do? Yeah, that's hard for me to do, and I think I'm a reasonably intelligent guy, and I have a lot of difficulty doing that. But with a spacer, you can shoot it into the spacer, or the holding chamber, and then inhale. How much easier is that? What do you guys think? It's a lot easier to do it that way. And it's great for little kids, because how are you going to tell a little kid, no, don't inhale? No, so you squirt it into the holding chamber of the spacer, optimally the holding chamber, squirt it in there, okay, here you go, inhale, slow, hold it, okay, good. It's a lot easier to do it with a spacer. So I definitely recommend using it whenever possible. And yeah, it allows the patient to have something in their mouth. Okay. Some patients have difficulty coordinating, and we talked about that already, that lots of people, myself included, have difficulty coordinating. Okay, so here's the MDI. Canister goes in here. The actuator's here. So here I have an example of a holding chamber. Just plugs in. I squirt it, shoot it in here. It's in suspension here, and then the patient can inhale. And here's just another example. Looks a little different, but it does the exact same thing. Okay, 60-70% of patients do not use their MDIs correctly. There's a big surprise. So good education, guys. We need to educate our patients very well, especially when we get into clinicals. Because what happens when you've been a therapist for 5, 10, 15, 20 years? You don't care as much, do you? That's just human beings are that way. We get complacent. We don't care as much. And we need people like you to come in and remind us that we need to do things right, because you guys will be doing things right. You guys will take very good care of your patients because you know to do everything right, and you're really worried about doing things right. So sometimes we don't educate patients like we should. But the beauty of you guys, the beauty of being students, is that you will have time in clinicals to really talk to patients and educate them, and to you can make some really neat differences. Sometimes when you're actually working as a therapist and you have a whole floor and the ER is calling you for this and that, this doesn't happen. You forget about it. So it's great as students to really spend time with good education. Okay, so instructions. I'm going to grab an MDI here in just a little bit, and I'll show you guys. But we'll assemble it, shake it well, exhale normally, put the spacer in your mouth, keep your tongue down and out of the way, depress it, inhale, and again, you want to position the inhaler about 2 to 3 centimeters away from the mouth. If we're using a spacer, not necessarily, but if you're not using a spacer, you need to get that MDI out of their mouth. Okay, begin taking a slow, deep breath. So you actually want to be inhaling when you actuate the MDI. Then breathe, hold it for 10 seconds if you can. Breathe out normally. Wait a couple minutes for the next puff, because sometimes the order will be 2 puffs or 3 puffs or 4 puffs, depending on what the order is. Okay, steroid. Rinse your mouth and throat. And that was a big blue light special. Small volume nebulizer. Okay, small volume nebulizer is the quote-unquote breathing treatment that we all talk about. And have you guys ever seen these? Nope, you will, don't worry. It is basically what it is, I've got a picture here, but it's a device that uses a gas-powered source. So a gas goes into the device, and the gas actually nebulizes it. This is continuous. It lasts anywhere between 8 to 12 minutes. You squirt the medication into the device. You'll generally close it. There'll be a mouthpiece on the device. Gas will go in. You'll turn your flow up anywhere from 6 to 8 liters per minute, and then the patient will inhale and exhale for 8 to 12 minutes. Sometimes, if the patient can't hold it, you'll actually hook it up to a mask. Numerous breaths to administer medication. The most common type is called the SVN, or the small volume nebulizer. Ideal pattern still holds true. Slow inhalation with an inspiratory hold and a normal exhalation. Mouthpiece is preferred because we can get better deposition and we can work with the patient a little better there. And I'm not getting aerosol sprayed all over the face like I would with a mask. But sometimes we need to use a mask. Some disadvantages, they need to be cleaned and cared for more than an MDI. It's a little more maintenance intensive. And have you guys talked about infection control in lab? Not yet? Okay, I'll give you guys a little hint. You'll sound all smart in lab. The most common concern for infection, for us at least, is the large volume nebulizer. It's like a small volume nebulizer when it's really large, and we put lots of medication, and this is what we call delivering medication continuously or for an hour. Because I have lots of fluid in those things, and they're open to the atmosphere, the environment, infection is a big concern. So hopefully they'll tell you guys that whenever you guys do that. Okay, bulkier, I need a gas source, sometimes I need a compressor if I'm at home. Patient doesn't assist as much, and a small portion of the dose can't be nebulized, and this is what's called dead space volume. So I'll squirt the medication into my small volume nebulizer, and there will be a little bit at the very bottom that will never get nebulized. It doesn't matter how much you shake it, and your patients will be pretty adamant about, oh, shake it some more, shake it, I got to get all of it. There's going to be a little bit of it that just won't get in. And here we go. This is what they look like. Obviously, it's a little larger than that, but I basically have three parts to it. I have my mouthpiece, which attaches to the top. I have my top, which actually generally will unscrew from the bottom part. And what I'll do is I'll put the medication in the little bottom part here. Then I'll screw the top on, put the mouthpiece on the top, and then I'll have my gas source. The gas goes through here and nebulizes the medication. The medication passes up here. The patient can inhale and exhale, inhale and exhale. So you will have some misting coming out of the end of that. And that's okay. You want to see misting coming out of the end of that. Continuous nebulization, this is what I talked about for people that are in very severe distress. I can administer for longer than 8 to 12 minutes. I can go for an hour or more sometimes. And sometimes when you guys are in the ER, they will ask you to do an hour-long nebulizer, and you will give a very large dose albuterol, possibly some steroids, and you will administer that over an hour continuously. Have you guys ever heard of the word status asthmaticus? Status asthmaticus is a very severe asthma attack that has gone on, and the patient has tried to treat it at home, and it has resisted treatment. It is what we call refractory to treatment. You'll often see that. Certain patients, other types of COPD, you might see that as well. Okay, effective for patients with severe pulmonary disease. Okay, continuous nebulizers. These are what we call the large volume, or the LVNs. The small volume was a little handheld nebulizer. These are LVNs, large volumes. The two common ones that you run across are the Heart and Hope nebulizers. Requiring high doses need to be monitored, obviously, because I'm going to have some problems. Tachycardia, arrhythmias, and hypokalemia is something that can occur with what class of drugs? So hypokalemia is low potassium, and what class of drugs cause it that we give? You guys remember from your drug cards, or bronchodilators? Yeah, things like albuterol, yeah, can cause hypokalemia, bronchodilators. Okay, DPI, dry powder inhaler. So this is something, this is a little, have you guys seen commercials for like the Advair Discus and some of the other, you got a picture of it in your book, or some have the newer book, there's a picture of it, it's like green. The older book, it's kind of a gray, but it's a disc, it's literally a disc, it has powder in it, and there's a little lever that you pull back, you click it, and it drops a little bit of powder, and then you have the patient inhale that powder. Now, are you going to see anything nebulized? Anything going to come from it? No. There have been cases where people went ahead and activated the disc, didn't see anything, and thought, oh, shoot, this isn't working, and they activated it a couple more times, and then gave it to the patient. The patient got a really big dose of medication. Often, a lot of your steroids are delivered this way through DPI or your combination medications. Okay, so dry powder, no propellant or external power sources. So the patient, and this is a bit blue light special here, for this to work, a patient needs to be able to generate at least 50 liters per minute of inspiratory flow. So I need to be able to inhale pretty efficiently for these guys to work. So if somebody comes into the emergency room and having an asthma attack, do you think that that the doc is going to want me to go for the dry powder inhaler? No, this is for maintenance medication primarily. This is to prevent that asthma attack, the steroids and all that. But we would never use this to rescue somebody. Again, because they have to have really good inspiratory flow to use these devices. Okay, Advair. Have you guys ever heard of Advair, the Advair Discus? I actually take Advair. Pretty common. It's a combination medication, a steroid, and a long-acting bronchodilator. Okay, so advantages, disadvantages. Again, the big thing is at least 50 liters per minute of inspiratory flow. But it doesn't contain propellants. It's easy to tell how much of the drug is left, right? Because with a metered dose inhaler, you don't really know how much drug is left, right? Some of them actually have little counters on them. These always do. They may talk about in the book where you can actually put the canister in water from metered dose inhaler, and if it kind of sinks to the bottom, it's full. If it's floating halfway, it's half full, and if it's floating on top, it's empty. That's not a great way, but it's a kind of a rule of thumb that you may hear talked about. Okay, so MDI, metered dose inhaler, everybody's good there. Patient can follow instructions, has a stable breathing pattern. Small volume nebulizer, or SVN, DPI, dry powder inhaler, and then if it's really bad and I need to give continuous medication, there's something called the LVN, or the large volume nebulizer. Okay, patients that are intubated and on ventilation, I'm not going to focus on this a whole lot because we haven't talked about intubated patients yet. But patients that are intubated, they have a tube in their trachea and they're on a ventilator machine that's breathing for them or helping them breathe. We can administer aerosolized medications to those patients as well. It requires some modification, but it is very easy, and I don't worry, you guys will get opportunities to administer medications to intubated patients, both MDIs and small volume nebulizers to intubated patients. So don't worry about this too much. Just know that we can do it. Okay, aerosol intubated patients. Again, I don't want you to worry about this a whole lot because we're going to talk about it a little later on. Just know that we can do it. Okay, guys, what I'm going to do is I'm just going to run in the back room there and grab